أهلا بكم. We will continue our comprehensive schedule, and it is my pleasure to thank Jensen for the supporting of the conference this year with this very important symposium. It will be presented by my dear colleague, friend, عايز اقول ايه، ابني الحبيب يعني، لو سمح لي.
ده شرف والله يا بيه.
الله يخليك. دكتور شادي فاضل, Associate Professor of Clinical Oncology in Alexandria University. He will give us an important talk about the role of Darzalex in management of early diagnosed multiple myeloma. This is important point because it present a new line of treatment, a new mechanism of action, different than what we used to do in multiple myeloma. Please, Dr. Shady.
Thank you, Dr. Abdsalam. Thank you, Jensen, for the opportunity. I will discuss today the role of daratumumab in the first line of treatment of multiple myeloma. Dara is already present for the relapsed patient, but the topic of this presentation would be the first line. First, the magnitude of the problem, the multiple myeloma. This is the SEER data yesterday on the SEER's website. In the United States, you have 32,000 new cases per year of multiple myeloma. Given the demography of the United States, we could and our demography, we could expect that we would have about 1/6, which is about 5,000 to 6,000 new patients per year in Egypt having multiple myeloma. And consequently, we'll have a death of about 1,000 to 2,000 patients per year in Egypt. And you could see that the trend, that there is an increase in the number of the new cases, and this could be attributed to the aging of the population, because the median, the life expectancy have been increased in most of the world, and multiple myeloma is a disease of the elderly, and the incidence will increase dramatically after the age of 50 years. So as the population ages, the incidence of multiple myeloma will increase as well. And the death rate since 1992 showing a mild improvement. This is the demography of Egypt. This is the life expectancy of Egyptian male and females since 1950. You could see in the 1950s the median age, male and female, was around 40 years, while now it's about 76 for the males and 82 for the females. So given this demography, it's expected that the number of multiple myeloma cases will be increasing because of the increasing age of our population. Like every other hematological malignancies, the depth of response is important in determining the outcome of multiple myeloma. This is the natural outcome. If you have an active multiple myeloma, you give the treatment, then after some time, first relapse will occur, another treatment, but will not go to the same depth of remission, so the second relapse, and subsequently the patient will succumb to the disease due to the relapses. So it is assumed, like we do in leukemia now, that if we have a deeper response, we will have a delayed relapse or eventually non-relapse and cure. So the hypothesis, if you could induce a very deep response using multiple drugs with different mechanisms, we could reach eventually at a cure. And this could be estimated by the MRD, the minimal residual disease, as we will see later. This is how, when you see a patient with a multiple myeloma, you classify your patient according to the transplant candidate, if he's candidate to transplant or not. You have two pathways. And this is not only a function of age, it's a function of the comorbidities, the general condition, the patient willingness, the availability of the resources. So at the end of the day, if the patient is a candidate for an autologous transplant, you will do an induction with 2 or 3 drugs, 4 to 6 cycles, followed by the autologous stem cell transplant. Then you have one of 3 options. You give a consolidation with the same drugs, you give the induction, or you give a maintenance therapy with a lenalidomide, or you do nothing. However, if the patient is not transplant eligible, due to the comorbidities, you could give 2 or 3 drugs for 12 cycles, plus maintenance therapy or continuation therapy with the 2 drugs. This is the schema that we follow in our patients. What are the evidence behind this schema? These are transplant-eligible patients. We have 2 randomized trials that have shown that 3 drugs is better than 2 drugs. This is the first study, the SWOG study, that have shown that VRD, bortezomib, lenalidomide, and dexamethasone is better than lenalidomide and dexa, the RD. It's a 525 patient phase 3 randomized trial. And you could see that nice separation of the curves of the progression-free and overall survival, with a median progression-free survival of 43 months. Sorry, the slide is not showing well here. 43 months versus 30 months for the VD. So VRD is a standard of care for transplant-eligible patients who, after 4 to 6 cycles of VRD, will go into autologous transplant. Another study is adding of the bortezomib to the melphalan-prednisone, the historical standard of care for multiple myeloma with MP. When you add V to the MP, the VMB, it's again nice separation of the curves of the overall survival, 56 months versus 43, which is statistically significant. However, most centers for transplant-eligible patients will not go to this regime because of the presence of the melphalan, which will decrease the yield of the stem cells that you need to do the transplant. So mostly, if you are going to transplant the patient, you use the VRD or the VTD to replace the Revlimid with a thalidomide. While if you have an older unfit patient, you still could use the VRD if the condition is good, but not good to transplant. Or you could replace the lenalidomide with a cyclophosphamide. You give the Velcade, the dexamethasone, and replace the lenalidomide with a cyclophosphamide if the patient has renal impairment, because patients with renal impairment will have severe toxicity from the lenalidomide. However, this combination, the cyclophosphamide, bortezomib, dexamethasone, was not validated in a prospective phase 3 study. Only a phase 2 study was done. If the patient still is more frail, you could use a doublet rather than a triplet with the VD or the RD, bortezomib plus dexamethasone, or Lena with dexamethasone, or even VMB in younger and fitter patients. So in these transplant-ineligible patients, could we improve on 2 drugs, the RD, for example? The DARA was tested, the DRD versus the RD, in a randomized phase 3 studies, more than 700 patients. And you could see nicely the separation of the DARA arm than the RD arm. This is still not mature study. It's published and approved, but yet the follow-up is, median follow-up is not that long. Median follow-up 28 months. You need a longer follow-up to know what is going on. But you could see here this part of the curve that there is no more slope. It's a flattening of the curve. And we have, to the first time, demonstrated that MRD, minimal residual disease, if it became negative, it will affect the outcome. And if you are not aware of what is MRD, it's testing of the presence of malignant cells using a very sensitive technique by flow cytometry, PCR or NGS, and you could detect as low as 1 cell per million white cell in the bone marrow. If you detect 1 cell per million, this is a positive MRD. If you do not detect 1 cell in million, this is a negative MRD. So if you give DARA, Darzalex, and you get an MRD negative, 24% of your patient, transplant ineligible, will stay in remission, a quarter of your patient. Still, we need longer follow-up. So what is Darzalex? Darzalex is a monoclonal antibody, humanized, acting against CD38. CD38 is overexpressed in the myeloma cells, and as well as other lymphoid cells like the T cells and the NK cells. And how does it act? It acts by 4 mechanisms. The first mechanism, the complement-dependent cytotoxicity. When DARA attached to the CD38, the complement will come here and cause a MAC complex to cause the lysis of the myeloma cell without the need of any other cells. or antigen-dependent cytotoxicity. The complex DARA CD38 will invite the natural killer cells and other group of cells, macrophage, neutrophils, and T cells that will cause lysis of the myeloma cells. The third mechanism is the antigen-dependent cell phagocytosis, where the complex DARA CD38 will invite the macrophage to do phagocytosis of the myeloma cell. And this is the novel mechanism of action, is the immunomodulation effect of the DARA. You know that myeloma cells that residue inside the bone marrow, in the niche of the bone marrow, with a microenvironment that will promote the survival of the myeloma cells against the treatment that you give. And this is through the hiding the myeloma cell from the immune system. What the DARA will do, that it will inhibit the immune inhibitory cells and will expose the myeloma cells to the action of the immune system. One problem is the DARA, that when you diagnose your patient and you want to follow up, you do electrophoresis. The DARA, the anti-CD38, in the gel, it will run and residue with the M band. So if you are doing an electrophoresis to follow up your patient using DARA, tell the lab that you are using DARA, because in the gel it will appear as positive M band. So the lab need to put something that I will show you now on the sample to avoid this misinterpretation. Again, the DARA will interact with the typing, the phenotyping of the RBCs. So if your patient receiving Darzalex and he developed anemia and you want to transfuse the patient, be careful that this patient, when you do the ABO typing, it could be false. So what we advise that you do the ABO typing for every patient going to receive the daratumumab before receiving the daratumumab. And every time you ask for packed RBCs transfusion, you tell the blood bank that this patient is on DARA, because they gonna do use some chemicals to neutralize the DARA in the sample, so they could have a good result. This is either the DDT. This was published 2014 in the ACR, American Society for Cancer Research, or you could use an anti-idiotype antibodies against the DARA to neutralize it in the serum. So you should tell the lab and the blood bank that this patient is on Darzalex. So now moving to the first line, if you have a patient that is transplant eligible, young fit patient, the standard of care is the VRD, bortezomib, lenalidomide, dexamethasone. You could change the lenalidomide with another IMiD, which is the thalidomide. Could we, by adding a fourth agent, get a better result? This was a question of the Cassiopeia study. Will they randomize the patient between VDT, is Velcade, the bortezomib, T is the thalidomide, and D is the dexamethasone. This is the standard arm. And then to the standard arm, we add Darzalex, the DVDT. These patients are good performance status. They are transplant eligible, younger than 65 years of age, good renal function, and they could include any form, high risk, low risk, stage 1, 2, 3 ISS, or any site. And then you give 4 cycles of the VDT or the DARA VDT, and after 4 cycles, patient will undergo an autologous stem transplant. Give 2 more cycles of the same regime that you have given before the transplant to complete 6 cycles, and then another randomization of maintenance with nothing or with Darzalex. This is the study design. Demography showing equivalence between both groups regarding age, sex, performance status, cytogenetics, the high risk or low risk, the cytogenetic, the deletion of 17p or translocation 414, these are the high risk, were equivalent between both groups. You could see here, this is after induction, this is after the transplant, 100 days after the transplant, and this is the best response. This is the green one is the DARA arm, while the black and white is the non-DARA arm. These are the stringent CR and CR. Stringent CR is clinical CR plus CR in the flow, in the free light chain. So it is a clinical CR that we know, no plasma cells, no active lesion on the PET scan, and M protein is negative, plus free light chain will be negative as well. This is a more CR than, the stringent CR is more than the CR. This is 14% after induction. It increased to 22% after the transplant. It increased to about 38% 100 days after transplant, and even later, you have about 60% increase in the stringent CR. This stringent CR is 60% increase by the addition of the DARA to the triplet, the VTD. If we look at the minimal residual disease, which is the aim to have a deep response, post-induction, still DARA is better than non-DARA arm, and 2-cycle post-induction, still the difference is statistically significant, with 45% increase in the negativity of the MRD. This is the progression-free survival. A median follow-up of only 18 months. This is not so long. But however, at this early stage, you could see quite the separation between the two arms, and even the separation is getting more and more with more time. There is an increase of 53% reduction of progression or death by the addition of DARA to first-line transplant-eligible patients. And we hope that this part of the curve will continue to be straight and no more patients will be relapsing. If we look to stratify patient by the MRD, you could see that both arms with MRD positive or negative, MRD negative patients are doing better than MRD positive, of course, in both arms. But MRD positive with DARA is even better with MRD positive without DARA. What is the most important here in this curve is this curve. Patient who receive DARA and MRD negative, it's almost flat. Almost very few patients relapsed if you could achieve an MRD negative, which is a surrogate of the depth of the response, like we are used to do in the ALL and AML. The depth of response in the pre-specified group was in favor of DARA all across the board. MRD negativity across the board favors DARA. And the durable progression-free survival that has been increased across the board again in favor of Darzalex. So we are giving 4 drugs compared to 3. So the first question came to your mind, what about the toxicity? You could see there is no much difference in the toxicity. 4 drugs have discontinuation of the treatment. When you discontinue the treatment, if the patient could not tolerate the treatment. So the discontinuation rate is similar, 7 and 8% in both arms. Grade 3 or 4 infection, which is very important in elderly patients, about 20% in both arms. And there is new signal that we didn't identify any new side effects that we do not know from the triplet. More hematological toxicities, more bone marrow suppression for the Darzalex arm, and of course infusion reaction, because the VDT there is no infusion. You give the Velcade subcutaneous, the thalidomide and the dexamethasone on oral, but if you give Darzalex, you will infuse the patient, so you have, this is a monoclonal antibody like the rituximab, like the Herceptin, you get an infusion reaction, of course. But all the infusion reaction were low grade. 35% of patients developed infusion reaction. Very few have grade 3 or grade 4, 4% only of the patients have grade 3 or grade 4 infusion reaction. And most of the infusion reaction occurred in the first cycle, the first infusion of the Darzalex. The infection rate is comparable between both arms, and grade 3 or 4 is equivalent. Only 1% of patients stopped the Darzalex due to the infection. And other patients developed infection, but after resolution of the infection, patients continue to receive their treatment. This is a schema of how we give the DARA. The Velcade subcutaneous to decrease the neuropathy, thalidomide oral, dexamethasone you start by a 40 milligram, then when you go to cycle 3 and 4, you decrease to 20 milligram, and the post-induction, post-autologous transplant, you go to the 20 milligram. DARA in the first 2 cycles you give weekly. Each cycle is 4 weeks, so you give 8 infusion in the first 2 cycles. Then later, you give every 2 weeks, twice per month for the third and fourth cycle. The 2 cycle, the post-transplant, still you keep the regimen every 2 weeks. And later for the maintenance, you give 1 infusion every 2 months, every 8 weeks, until progression or 2 years of maintenance. This is how you try to decrease the infusion reaction, as most of you do with other monoclonal antibodies. You give the paracetamol, you give an H1 inhibitor, you give a mast cell stabilizer, and you give corticosteroids as a part of the treatment, which will decrease the reaction. If the patient is already asthmatic or having a chest disease, you could add post-infusion, you could add this medication, the salbutamol, or give also the treatment that the patient is already on, inhalers that he uses. So to sum up, this is a first phase 3 trial that shown that Darzalex will improve the outcome by 53% in patients who are transplant eligible. Minimal residual disease is better far away with the adding of the DARA, and the deeper response, we hope that it will predict a better outcome later. Still, there is a mechanism of resistance for the anti-CD38. It's if you give a single agent daratumumab, you have 60% of patients will having less than partial response, and eventually all patients with a single agent daratumumab will relapse. So we need to understand how the resistance will occur so we could overcome it. You could have an escape of the CD38. You give a drug against the CD38, so you choose the clone selection, you will kill the myeloma cells that is expressing the CD38, while the clones without the CD38 will survive and cause the relapse. Or there will be a down-regulation of the CD38 when there is a stress on the myeloma cell to give an anti-CD38, the myeloma cell will internalize the CD38 or the macrophage, and the neutrophils will cover the CD38, which is the target of the drug that we are giving. Or you know that the NK cells and the other immunomodulatory cells express the CD38. These cells are important to kill the myeloma cells. So while are you killing the myeloma cells with the anti-CD38, you are down-regulating the cells important to kill the myeloma cells. Or the myeloma will express CD46 that will inhibit the complement, or CD47 that will inhibit the macrophage. So if you want to overcome these, you will give drug that will overexpress the CD38, like the Atara. If you give an all-trans-retinoic acid, it will increase the expression of the CD38. Or you could give an inhibitor to the CD47 or the CD46, and this is under trial. Or you could take the NK cells from the patient and you do an ex vivo expansion of the NK cells and do reinfusion of the NK cells, like the guys at Amsterdam University. They are doing this trial now. This, again, how you would overcome the resistance against daratumumab. We did not answer all the questions. Still, we do not know if we add more to the 4 drugs. If we add the ilutuzumab to the 4 drugs, will it have a better outcome or not? We do not know. If patients who are receiving 4 or more drugs and achieving MRD, still we are going to do a transplant or not, we do not know. And of course, how we will do the financial toxicity with the 4 or 5 drugs. This is a hell of money you want to pay, but and does it cost effective for the economy of the country you are living in or not? We do not know. So these questions need to be answered so we could know where we are going. Our take-home message that daratumumab Darzalex is an anti-CD38 monoclonal antibody affecting multiple myeloma cells as a single agent or in a combination, of course. If we understand well the mechanism of action and mechanism of resistance, we could get more responses by ameliorating the mechanism of resistance. And DARA, it provides a benefit at first-line treatment for both transplant-ineligible and transplant-eligible. The transplant-ineligible patient, the DRD, DARA, Revlimid, and dexamethasone, and the transplant eligible is the DARA with the VTD as the Cassiopeia study we have shown now. And thank you very much.
Thank you, Dr. Shady. Actually, I have to say again, it is very impressive presentation. Very low tone, clear. The message is clear. The drug is quite impressive in its mechanism of action, and it make a real difference in the outcome. And it has a clear strategy in overcoming the resistance with the magic, what I said, magic drug, which is the Atra. I love it. This medication which change a lot the outcome of many leukemia cases. And what is really impressive and important, and I wish all our junior colleague, to look at the new addition and the new term that we are using now in oncology. The depth of response, the minimal residual disease, these are terms that should be considered in all cancers that we are dealing with, and this should be the new rural that we have to measure any medication compare, any technique of treatment compared to the other. Also, the strategies to overcome resistance. Why this is important? Because if you know the strategies of to overcome resistance, you really deeply understand how this drug is working. Really, thank you, Dr. Shady.
Thank you, Dr. Absal.
The floor is open for questions.
It was
Okay.
too clear to question.
Tfadal.
Too clear to have a question.
Thank you, Dr. Shady,
Thank you.
and thanks again to Jensen for supporting the program with this very interesting symposium.